इधर। Already 240. Amit. सोमशेखर, we can start now. Amit. हाँ जी सर. 240 हो गया. I think we should start. मैडम ज्वाइन कर ली.
So, ma'am will join. अब हम start कर देते हैं. Gradually, ma'am join. Good afternoon, everybody. We are 60 plus people on board now. We are here on the KMC day, or rather the KMC week, which we very proudly, lovingly celebrate. NNF has been a great promoter of newborn related activities, and KMC is currently at the core of care of newborn babies, especially preterm high risk babies. And in view of its eminence, and even government is pushing KMC a lot. So we are having this webinar, and the topic for the day is KMC and practical aspects to see. KMC is prolonged skin to skin care. So some may say, what is new? We are always doing skin to skin care. But yes, it is now with a vigor. It is now with science. It is now with evidence. And it is not just skin to skin contact, but also in addition to skin contact, there is a lot of emphasis on breastfeeding. And so it has been shown that KMC has numerous advantages, including better temperature regulation, better sugar regulation, more breast milk output, better breastfeeding rates, better weight gains, earlier discharge, and later also, once the baby is at home, all the comorbidities are lesser if the mother is and the family is giving KMC at home. So core components of KMC as discussed, one is skin to skin contact, the other is breastfeeding, then early discharge with follow-up advice for KMC at home, and entire family involvement. It should not be something which is just confined to the mother, because mother can't do say more than 4 or 6 hours in one go. So in this, father, grandmother, other responsible relatives at home can take part in kangaroo mother care and give all the benefits of KMC as we have discussed. Earlier, it was restricted to preterm babies, but now it is restricted to not only just preterm, but also LBW babies, sick babies after stabilization in NICU. And earlier, we thought it is basically for very stable babies who only require temperature control. And so in the ward, it can be given in NICU for stable babies. But now it has been shown that even babies on CPAP, on oxygen, and even ventilated babies can be given CPAP in the NICU itself. So with this intro on this KMC topic, I would like to welcome all the faculty who are here, and Dr. Srinivasan sir, Dr. Somsekhar sir, and led by our very own Professor Shashi Vani madam, who has almost, who's a stereotype or the star. Yeah.
The audio is not there, Amit.
Amit has very poor internet connectivity, so he must have gone off.
So, okay, then I'll take it forward. So, good afternoon, everybody. It gives me immense pleasure to welcome you all on this important webinar on the occasion of International KMC Day 2026. So this kangaroo mother care is not just merely a intervention. I can say this is a warmth, love, dignity, and survival that is wrapped in the mother's embrace. So in today's rapidly advancing neonatal care, KMC reminds us that healing is one of the most important, parents' touch is one of the most important part of the care. So over the past few decades, India has made remarkable progress in reducing the neonatal mortality through collective effort in NRP, breastfeeding, then promotion of infection control, and strengthening NICU and SNCU. And also, of course, the KMC. So despite this progress, prematurity and low birth weight continue to remain major challenges. And KMC has emerged as one of the most cost-effective intervention, and a study has shown there is significant reduction in neonatal mortality, hypothermia, infection, along with improved breastfeeding rate and neurodevelopmental outcome. So I'm also happy to know and share that the government of India is actively moving towards this integrated KMC, then family center care, along with nurturing care module. And this government is planning TOT, and definitely this will further improve the neonatal survival and quality care. Today, I would especially like to acknowledge everybody who are talking and pay my gratitude to our respected past president, Professor Sasiwani ma'am, who many of us truly consider the mother of KMC in India. So ma'am's dedication and passion, tireless advocacy, really are source of inspiration for most of us. I still remember nearly 9 years back when I was secretary of neonatal NNF, and we conducted two TOT, and one was in Srinagar. Ma'am traveled throughout the night and reached Srinagar in the morning, took the session and went there. So ma'am, you are really source of inspiration for all of us. I would also like to acknowledge the contribution of so many stalwart in the KMC, Dr. Somsekhar, Dr. Suman, Sugandha, Dr. Chelani, Dr. Ramesh, Arti, and Dr. Srinivasan, and many more who work relentlessly to strengthen KMC and family center newborn care in India. We at NNF are fully committed to promoting and strengthening this family center newborn care, KMC, and of course today is the IKMC, and also capacity building. And we are having a strong pool of around 200 KMC trainers, and they can take this mission forward. So I sincerely thanks all the distinguished speakers, moderator, participant for joining us today for this important initiative. So friend, let us continue working together with one shared mission. No newborns should be deprived of the warmth and all the senses of the kangaroo mother care. So with that, thank you very much and welcome everybody once again. Over to Somsekhar. Amit, join ke. Amit, are you there?
Yes, sir, I am there.
Yes, sir, please
Just
take
got
it forward.
disconnected. So with this introduction to the topic, and we can go on to the lectures directly. And Professor Shashivani madam has joined. Welcome, ma'am. She's a past president, and as Dr. Lalan said, she's said to be the mother of KMC. And in fact, the M seems to be Shashivani madam in between, ma'am. So, ma'am, can we go on? Can we start the session with Professor Shashivani madam directly?
Amit, I think Vani madam might find it difficult to share the presentation.
Yes, so
I'll
Devan,
share.
do you have the talk?
Debarun, can you?
Pass hoga. Debarun, you can share.
Debarun, can you make the presentation full? And madam, आप mute करके then you can say next and we'll move the slides.
But
you just-
can you hear me?
Yeah, we can hear you now, ma'am.
Yes,
Can
But
hear
I
you
am
now.
not able to see anything.
No, we can hear you, ma'am, and also we can see.
We will start the presentation, ma'am.
Okay. then-
Debarun, please share the presentation.
He's doing it. He's doing it. I just had a word with him. He's doing it.
Because
full,
there is,
full.
I don't know, something I lost again.
मैडम आपको दिख रहा है ये स्लाइड दिख रहा है?
नहीं दिख रहा है.
मैडम को नहीं दिख रहा है.
हाँ,
क्या
मैम
होता है ऐसा?
I think I need to connect again.
मैम,
No, ma'am, you are
आवाज तो आ रही है,
connected.
मैडम, आपकी आवाज आ रही है.
Madam, you are visible, madam.
But
Ma'am,
nothing is visible to me.
मैम नीचे जूम में नीचे ट्रे में जूम दिखता है नीचे वाले एकदम लोअर में जूम क्लिक ऑन दैट जूम सी इफ यू
सर
कैन
उसको क्लिक करके देखिए. हाँ,
नीचे जूम में
Anyway, very small it is seen. I really do not know.
जूम दिख रहा है मैम नीचे?
फिर से कर लीजिए.
जूम तो दिख रहा है.
हाँ,
ये स्लाइड भी दिख रही है बट बहुत
अच्छा.
छोटी है. कैसे उसको मैग्नीफाई
मैम, आप
करूं?
हाँ
अपने
मैम
स्लाइड शो कर लीजिए. अच्छा,
नहीं मैम वेट ललन वेट जो स्लाइड छोटा दिख रहा है मैम उसके राइट अपर कॉर्नर में देयर मस्ट बी एरो क्लिक ऑन दैट इट विल बिकम फुल स्क्रीन. जो स्लाइड छोटा दिख रहा है वहां पे राइट अपर कॉर्नर में एरो होगा.
यस ओके.
हाँ हो गया. हाँ ओके
बस हो गया.
थैंक यू.
Now it is done, ma'am.
Okay. Thank you very much for all the kind words and mainly for arranging this session. This 15th May is everywhere internationally celebrated as KMC Awareness Creation Day. So that is why I requested NNF President Dr. Lalan to organize something. Last year also we had organized. So I'm really thankful that within a short time also you have done a wonderful job. And I have been given the most difficult topic today, that is strengthening the KMC practices in private healthcare institutions. It was, of course, a big challenge, but somewhat we have succeeded in the public sector. But in private sector, we have to go a long way. So we will quickly go through these things in the available short time. Next one, please. So now we find gradually a few private institutions have started practicing KMC, but they are really, we can count them on our fingers, not many. And that is why we want to take it to a big level. Next, please. So these are all the private sector people. And this group, of course, knows that what is Kangaroo Mother Care. But mainly, as Dr. Lalan has also emphasized, I want to emphasize in the definition that KMC is a humane and emotionally supportive care. That is the importance of it as concerned with many other factors. I won't go in detail in this crowd, but now it has been really acknowledged because of the direct skin-to-skin contact on mother's chest. There are so many emotions and so many sentiments which have been stimulated, and hormones and neurotransmitters are generated, and that are responsible for more and more benefits. Every day we are coming out and realizing there is one more benefit, one more benefit. So with all these benefits, still we find that though it is now a low-cost intervention and high impact, but low intake, and that is our concern. Next one, please. So now we have realized that KMC is the game changer of newborn care, and almost everybody has now started speaking in the same language, including WHO and other authorities also. Next, it can be done at any level, and mainly it helps for the not only mere survival, but an intact survival, well thriving, a well-nourished child, well-behaved child, and all the qualities are there. It includes within it developmentally supportive care, nurturing care, family participatory care, and role of family members, particularly mother as the prime caregiver, other than being mere visitor to the unit. Next one. And KMC Foundation has been working with these themes dedicated for the promotion of Kangaroo Mother Care. Of course, our overall aim is to improve newborn care in India, but we particularly dedicated to KMC because at that time there were not many takers for this. And we promoted that mother's chest is the best place for the newborn care. Mother's milk is the best food for the newborn, and zero separation of mother and her baby. And over the period of times, we are happy to note that all our statements are fully endorsed and being taken further by all the international agencies and authorities. And our vision at that time itself, when we formed the foundation way back in 2015, we had decided that KMC should be a part of routine care for all the newborns, of course with special benefits for low birth weight infants and preterm babies, and not to be considered something different and special. It should become a part of our routine care. As a matter of fact, it should be included. And we are really happy that the same theme is now again endorsed by WHO. And now we have added one more sentence also, that incubators or warmers should be used only when KMC is not possible. In fact, everybody should explore all possible facilities to promote Kangaroo Mother Care in whatever way they can. Next. And why is there, this is a very special statement for me, that in developing countries like India with huge population, high neonatal mortality, and relatively weak public health system and inadequate facilities, simple interventions like breastfeeding promotion, kangaroo mother care, hand washing, and even local traditional practices that can save thousands of neonates from dying due to easily avoidable as well as treatable causes, provided at least 90% coverage is achieved. So this is a very important and encouraging statement for us. Rather than aiming for all the babies to be in incubators, warmers with all the monitors and gadgets, simple, doable, basic, natural interventions, they have much higher potentials in saving babies. Next. So we know 90% coverage has to be achieved, and Government of India has taken it up in its policy also, and it has been acknowledged as a core intervention and even included in the National Health Monitoring Information System also. And they had laid down the KMC coverage way back in 2015 itself, that by 2020 we should achieve 50% coverage, 2025 75, and 2013 90% coverage. And let us see where we are. Next. Now, first of all, exact data is not available. With great detail, if we go in, at least for year 2022, I was given this information that nearly 5.93 lakhs of newborns with low birth weight less than 2,500 gram admitted in 1,092 SNCUs in public health facilities at that time. And that time, they constituted almost 51% of the total 11 to 12 lakhs of admissions, and all these babies received KMC. And even in the medical college facilities also, there was no 100% coverage, but 75% of the coverage was reported. Now, I am saying reported because there are many flaws in the quality of data generated, the type of definitions assumed, and there was no in-depth analysis to verify all these facts. So, assuming with all the weaknesses of data collection, still we have achieved only barely about 50 to 60% maximum. Let us give some allowance. But even then, a lot of things to be done. But this is as far as those babies who are in the public sector. Next. And online factor. Next. Now, as I said, in private also they have introduced, but few have introduced. Next. And private sector exact data is not available. All the NNF accredited SNCUs and NICUs are expected to have KMC. And many private sector NICUs, including tertiary care units and intermediary care units, have stated KMC for stable and even mildly sick newborns who are stabilized on CPAP, oxygen therapy, IV fluids, medications, phototherapy, etc. But again, I'm repeating, no data is available, and we find many private people who are still hesitant to introduce KMC in their setup. Next. And what are the main barriers which we have perceived? No exact analysis has been done, but from our experience, we find lack of conviction in the usefulness of KMC or trivialization of KMC by the consultants appears to be one of the major pillars for the prevention of KMC practice. That includes even the medical college teachers also and senior consultants in the private setup also. And this is mostly due to inadequate information, knowledge, or no practical experience, and they just assume KMC is only a poor man's incubator, just putting the baby on mother's chest and whatever few benefits it may have, but that is relevant only for the lower income groups. So this idea is highly prevalent, and that is one of the major barriers we have to break. Apathy and reluctance, fear to change the existing system of newborn care for other reasons also is one. One is, of course, fear of harm to the baby. When you are giving the babies, mainly in the private nursing homes. They are with some IV lines, some tubes, and some intubated, and all these gadgets are there. The first harm is whether they will all slip away, or they will introduce more infection. We will have more harm to the baby, and so many things. Of course, practical problems like non-availability of space, trained staff, infrastructure for MNCs, which is the latest advocacy. These are all other major constraints. Private people are more concerned with the medico-legal issues and concerns also. So they are really sometimes, even with all their full conviction, sometimes they are reluctant to introduce KMC because they are not sure whether they are justified in starting KMC or delaying KMC or early initiation. So many questions are there in their mind. Monetary concerns are also there, whether they will be losing the income or whether they should charge for certain facilities which are otherwise rated as low cost, no cost facilities, and so many such issues are also facing the dilemma. This I am finding even with those who are fully convinced with the benefits of KMC. But the monetary concerns in the private sector is appearing to be a major concern. And in our setup, mainly, lack of medical insurance facilities for KMC, that is one major barrier we have to break down, mainly to promote in the private sector. Even for the newborn care also, there are so many dubious questions, and particularly for Kangaroo mother care, whether it has been recognized by insurance people, whether they sanctify it, what are their terms and conditions, all the details have to be looked into detail. Next. So having these barriers in mind, we are just going through some of the answers to these. First of all, it has been fully acknowledged that there are many benefits to the hospital, whether they are in the public sector or in the private sector. KMC saves money on the healthcare costs of newborn and even post-neonatal period by saving on the use of equipment, nursing staff, hospital stay, less medications, including less antibiotics, and oxygen needs are also much less, and formula use is also much less. And so many other ways you can calculate, but the cost definitely is much less. At the same cost, we can utilize our manpower for the better care and involve for them, nursing staff can be involved for the care of other needy babies also. And infrastructure also can be better utilized in the long run. Less scope for nosocomial infections. That is another major plus point. And less burden on nursing staff due to more involvement of mothers in the baby care. These are all well-acknowledged evidence-based benefits. Next. Next, please. And even in the countries from Sweden, Dr. UV Ewald is from Sweden, and one of the best centers, and with all the best available facilities, equipment, nursing staff, free services, and well-acknowledged, well-knowledgeable staff as well as clientele. Still, they have also advocated that the new place of care for the premature infant is the chest of his or her parents. Incubator warmer only when this is not possible due to some reason. So way back in 2015, in the 12th World Congress, he had declared it that newborn care, KMC is the best mode of treatment. Dr. UV Ewald had come to our conference in way back in 2012. He traveled 3 days on the last day of his retirement just to propagate this idea that KMC can be given to all the babies, including sick babies, and one of the best mode, much better than the equipment care. Next. Bogota Declaration, that international group of KMC experts, way back in 1998 also they had declared that KMC should be a basic right of every newborn, and it should be an integral part of management for all the newborns, including term and preterm babies in all the settings and all levels of care and in all the countries. That means Private sector is no exemption. Economically better section of community is no exemption. All the babies should have kangaroo mother care as a basic right. Next. And we know kangaroo mother care doesn't mean only holding the baby on mother's chest. It includes giving mother's milk as much as possible, either as a direct or express breast milk, and also planned early discharge with regular scheduled follow-up and all the details. And way back, for quite some time, we have been propagating that kangaroo mother care is relevant in tertiary care units of the newborns also. Next. And all the details have been given there, but the time limit, I'll just quickly pass through. So once again, we are emphasizing that the equipment can survive the baby, but the love and care which is required from the mothers and the loving hug which is required and which has got additional many benefits, immediate and long-term benefits, that can be provided only by mother's touch or loving hug between the mother and the baby. Next. And of course, KMC plays a key role in following ways. These are all international publications on these. First and foremost thing, it doesn't do any harm. It is developmentally supportive neuroprotective care even in NICU. Not necessarily that it should be practiced only for the stable, otherwise well-settled babies. Quality improvement initiative also, it forms a past, and so many other you can read from here. And it is a brain-friendly NICU measure, striving towards excellence in neonatal care. Next. And there are so many case histories where mothers have taken care of babies very well. All of you know, here are the twins. Next one. Then there are quadruplets reported from Baroda. Next slide, please. So quadruplets reported, and there are so many other benefits here. Next, benefits to baby, mother, family, community, and so on. And now some of our members have started introducing KMC even in the private sector. Here is an example where the twins are being given CPAP and the mother is holding the baby in KMC. And for each baby, one nurse is also dedicated, but still they are promoting KMC. Next. And why KMC is recommended in NICU? Again, for so many benefits, including infection, breastfeeding promotion, and other things. Next. And most important thing is, it provides an opportunity for mother and father or the family members to establish a critical relation with the infant and enhance parent-infant bonding, which helps the baby to cope up with the stressful situation and come out of it as early as possible and as successfully as possible. And simultaneously, it increases the parental confidence levels in subsequent care of these babies after taking them home. So all these benefits are much more important than other study benefits which have been mentioned. Next. Next, please. So same way, we are continuing with so many other benefits here. And just to ensure people that different cardiorespiratory parameters have been studied during KMC, and they have found that there are no harms done. On the contrary, there are certain benefits. So many from different angles they have studied, and they have found that it is beneficial even to the babies who are on mechanical ventilation. Next. So potential to reduce mortality is definitely there, and quality survival is definitely there. And that time, this slide was there. That time, our IKMC study had just been released. And from that also, we knew that it has got much more potential of saving almost 150,000 more babies if immediate KMC and the concept of zero separation was introduced, and KMC for the very sick and very preterm babies also introduced. Of course, there are a very few exceptions are there, that those babies who require urgent, immediate, life-threatening intervention, life-threatening situation and require immediate intervention, like those babies who require mechanical ventilation for respiratory distress, or those who are in severe shock, or those who require advanced resuscitation. But barring those few exceptionally critical babies, majority of the babies have benefit from early KMC. Next. And clinical application, again, we are saying, think of all possible situations in your NICU to keep the mother and her baby together. Minimize their separation. Change your policies. Like even we used to have in one day, if the baby was less than 1,000 grams, we used to keep it in NICU, mother was outside. Only periodically she was allowed to come inside. Then when there were twins, or suppose the baby had meconium aspiration, or baby was born by cesarean, all the time to keep this baby under observation, mother and baby were separated. Of course, mothers were allowed to be in the nursery, but not hold them fully. So like that, there were so many other policies and protocols were there by which we used to separate the mother and baby. But now we have to think that we have to keep them together. And accordingly, we have to train our staff. First of all, we have to convince them with proper explanations, counseling, and motivation of all the staff in NICU. Even before the patients, I will say staff conviction is much more important. They should have good quality training and then proper counseling. They will have proper counseling to parents and families, and they'll get cooperation, compliance, conviction for KMC during their NICU stay of the neonate. So ensure a stress-free newborn and mother with better quality of outcome by providing kangaroo mother care in NICUs also, and that applies for the private sector also. Babies are not different in public sector or private sector. Private sector have their certain additional concerns, but they have to come out of it. Next. So there has to be a paradigm shift, as I said. KMC was started because incubators were not available, but now we should incubators or warmers only when KMC is not possible. Next. So all out effort should be made. Next. So all of us, we know by putting baby on breastfeeding, and next on kangaroo mother care, we are allowing the baby to have a very familiar heartbeat. Baby is calm, baby feels safe and secure, and that has got so many advantages: less energy expenditure, less chances of hypoglycemia, and of course less chances of infection, and so many other benefits are there. So as far as possible, baby should be on mother's chest. Next. And the same way, baby, when it is in incubator, first of all, it is separated from its parents, exposed to strange sounds, scary smells, bright lights, and so many adverse effects, which increases the stress of the baby, and so many harmful cortisols and others are liberated, giving many other harmful effects. Next. So the concept of zero separation, we have to understand. Of course, others are going to talk about it, so I'm not going to go in detail, but that is a very important consideration, and that is one of the important consideration for practicing it even in the private sector. Next. After the baby comes out, we try to give a womb-like atmosphere to the baby by nesting the baby, covering the baby. But the same thing can be easily given on mother's chest or any other alternate additional caregiver's chest. So that is a simpler method. Only when the baby is not in KMC or other alternate providers are not available, then we go in for these methods. Next. Now, of course, this toxic stress factor also we have to remind, and mainly preterm baby, very preterm baby, low birth weight baby, they are separated from the mother for a long time, and that leaves irreversible damage to the baby, immediate or in the long term. So that we want to minimize. Next. I'm not going in detail with all these things. And now Recently, WHO has released their recommendations for the care of the preterm baby on 17th November 2022. And that is based on their new evidences and also the experiences and robust evidences generated by other KMC champions and researchers world over. And they all support this concept of changing the parameters and including many evidence-based suggestions in our day-to-day practice and upscaling the quality and widening the scope of KMC practice. And that is why they have also acknowledged that KMC is emerging as a game changer of the newborn care. At every level, kangaroo mother care has some beneficial effect. Next. So the same WHO recommendations I have given you here. Very first recommendation in preventive and promotive care setup is any KMC, means KMC is recommended as a routine care for all the preterm and low birth weight infants. And it can be initiated in the healthcare facility or at home. That is a major part which we notice. And again, KMC for preterm and low birth weight should be started as soon as possible after birth. These are all strong recommendations with high certainty evidence. Now, next, keeping these recommendations in view, now we just quickly analyze what are the newer recommendations. So earlier they said give only for the stable newborns, but now we have realized that it can be started as early as possible within 1 or 2 hours, even for the sick babies, except of course a few exceptions which I already mentioned. So that is one change which helps you, a major change. Next one. The older recommendations I have given you in yellow. Next, please. Now, all these recommendations I am particularly referring here because in the private practice, whenever some medico-legal issues come up, these officially released recommendations give us a lot of strength and support to justify our actions. So earlier KMC was recommended only for babies less than 2000, but now as I mentioned, all the babies less than 2500 gram weight or 37 weeks of gestational age. No specific recommendation was there earlier for the total duration of KMC in 24 hours of the day. We just mentioned start as early as possible, give as long as possible in 24 hours, but there was no hardcore recommendation. But now at least they have given an indication that minimum of 8 hours within a day and if possible, as long as possible in 24 hours. And for that, mothers can take the help of additional healthcare givers. And they are also to be oriented and trained just like mother. We counsel her, prepare her and train her with certain basic techniques of holding the baby, including hand washing, holding the safe baby, positioning and all. So the same training is required for them. Next. Next, please. Home-based KMC was earlier, people were reluctant to justify because they thought it was unsafe. Mothers were not be able to handle these premature or low birth weight babies at home. Chances of infection and other complications will be more. But now, with WHO mega experiments and our experiences, which we had done earlier also, and ICMR experience and many others experience, it has been realized that community-based, home-based KMC in different situations is quite safe, feasible, acceptable, and doable with many good rewards. I will not go in detail, but it is doable, that much I can definitely say. And for that, we need to train our community health workers or first-line workers, whosoever they are, properly train them, orient them, and allow them for frequent visits to the mothers. And they should have an art of counseling and convincing the mothers for proper holding and ensuring the proper quality even at homes. Next. KMC can be considered safe even for the transport of the babies. Short transport within the hospital, say from delivery room to the postnatal wards or from there for any investigations and so on, that is also permissible. And long distance traveling, when no other modes are there, KMC as a transport mode is very safe and very easily doable with multiple benefits. And it is not only in the poor countries because we do not have proper equipment, it is being recommended. Recently, even in Sweden, they have recommended this for all the babies more than 1,500 grams. And there are studies saying that in many situations, even the transport incubators can create harm in the babies during long distance transport, and chances of intraventricular hemorrhage and other complications can be there. Against that, carrying the baby on mother's chest or other alternative caregiver's chest gives a safe, warm, cozy environment to the baby, a safety factor, and of course, it allows. It does not allow for all these jumping and things which happen when they are in the transport incubators. Next. Cesarean babies also, now all of you know, we are strongly recommending that immediate KMC is possible. If the mother is otherwise healthy, she herself can be chosen to give the direct skin to skin contact. Only the position of the baby can be horizontal on her chest and promoting breast milk feeding as much as possible. But in case the mother is ill or she need to be observed for some time, and it is not possible to give direct KMC by mother, in that case, additional KMC providers who are chosen well in advance, counseled well, immediately available, their services can be utilized, and again it is much more beneficial. And for that, we need to develop proper protocols and proper training, taking in consultation all the obstetricians, anesthetists, and operating room nurses, and all the concerned staff. The concept of zero separation is also achieved here with all its benefits. Role of obstetricians is very important here. Even anesthetists is also there. So we have to take this matter very seriously, and NNF and others should take a lead in promoting this. Next. This is another simple intervention which is now being promoted, that even when the baby is not eligible for breastfeeding directly and express breast milk has to be done, as the milk is being expressed from the one breast, baby can be put on the other side of the chest. And that direct contact helps in early and more production of milk and easy collection of the milk. And this same concept is now being utilized even in the breast milk collection centers, which are affiliated to breast milk banks, human milk banks. So this is another simple thing. As a routine, in the process of express breast milk, we should include put the baby on KMC on one side and express the milk from the other side. Whether it is manual expression or pump expression, or that we can decide. But the baby should be on mother's chest simultaneously. Next. Full-term babies also can be given KMC. It is not usually mentioned in majority of the literature. Full-term babies generally are able to be in KMC for a few hours or at the most few days. But even that touch from the parents is very, very beneficial to these babies, mainly for preventing hypothermia, stabilizing their heart rate and respirations, and lesser chances of infections and early bonding. And these benefits are also very helpful, and at least no harm is done. And again, this concept is very much useful when we are using Kangaroo, when we are initiating Kangaroo mother care in the family situations, community situations. Many times, the workers are not in a position to weigh the baby or decide the maturity of the baby. They are perplexed. So it is not necessary that the baby should be weighed, and only if it is 2,500 grams, you put it on KMC. Any baby can be started with KMC. If the full-term mature baby is there, it will start wriggling out within a few hours or days. You can take it out. Others can continue with the KMC. So this concept and this knowledge is very helpful from that angle also. Next. At least there is no harm done. Considering all these recent recommendations, we find every day the scope for Kangaroo mother care in our situation is widening. Earlier, we were giving for stable babies, then stabilized babies with little IV lines and oxygen CPAP. And now even on mechanical ventilation also, people have started giving KMC. Even with central line also, they have started giving KMC. CS delivered babies, home delivered babies during transport. And one more simple intervention is as a non-pharmacological pain relieving measure for mild to moderate painful procedures, like say vitamin K injection you are giving, immunizations you are giving, or heel prick you are giving, or for any other mild to moderate painful procedures which you are doing. You ask the mother or the caregiver to hold the baby at least for 10 or 15 minutes in direct skin to skin contact, and then do the procedure. Baby will cry less, and the heart rate, respiration variations will be much less. And this is all a very useful thing. And as I said, term babies also can be given. And now there are emerging case studies showing that even in humanitarian crisis, like say man-made crisis, like wars are there, fires are there, or earthquakes are there, tsunamis are there. In all these situations, when the whole community is hither-whither, in that situation, if nothing else is possible for the newborns, at least the human touch can be given. Ideal with the mother. Even if mother is not there, some other human being can also help us by giving that touch. And even that saves many babies. And there are many personal anecdotes told to us on this. Next. So and the main purpose of all these recommendations I have mentioned, so that with confidence, you can introduce kangaroo mother care in private NICUs also. There are studies to justify that even critically ill babies can be handled well. There are no harms done. Of course, you have to train your staff well, and of course, you have to develop your protocols. But with all that, you will get the benefit of keeping the baby and mother together and get all the benefits of zero separation. Next. If I have time, then I can go for two other things. Hello. And keeping this in view,
Madam,
Kangaroo mother care.
Madam, we exceeded time quite a bit. So,
Do I have at least 2 more minutes? That's all.
Madam, exactly 2 minutes.
Yes, okay.
Okay,
So
ma'am.
KNC Foundation has initiated this exercise for a long time. Next one, please. Now quickly run the slides. And we have been having special workshops even for the private practitioners and tertiary care providers, how they can give KMC, along with many other workshops. Next one, please. And we have been requesting all the professional bodies also to be the signatories of KMC and promote Kangaroo mother care in their best possible. And you will see so many different agencies, including our NNF, IAP, and nursing associations. We have requested them to promote KMC since 2017. Next. And finally, of course, we have done this work, special meetings also. Next. 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 Now we have developed a 10-step for successful implementation of Kangaroo mother care on the same line as 10-step for the successful promotion of breastfeeding. Next. And finally, the role of professional bodies. I will just end up here. We want them to create awareness amongst their members and also conduct many training programs, prepare training materials in different languages. First of all, have a registry of those who are practicing Kangaroo mother care from the private sector. There is no such information available. So that is one of the important contribution which will help us for knowing the status of KMC coverage and going ahead further. And even for their insurance and all these common questions and issues, we must have separate meetings and promote them. If this advocacy comes from the recognized large bodies of professional organizations, all these can be attended to. In other countries, same thing has happened, like in Bogota, their KMC Foundation, they pleaded with all the arguments for the insurance people to give coverage for the KMC babies. So similarly, we should also do that. And in many other ways, we should try to promote KMC. I think I'll stop it here. Thank you very much.
Thank you, ma'am, for a wonderful presentation, a detailed presentation on a difficult topic, because there is very little data available on what happens in private, but because of the KMC Foundation and its focus on ensuring private practitioners do more KMC over the last 4-5 years that you have spearheaded and across various states, I'm sure it is going to improve quite well. We have had a lot of progress with your leadership the last at least 30 years in KMC, I think since 1994, 1995. So we are at more than 30 years of KMC work in India. We look forward to your guidance and support in NNF this year, next year, and the years to come, especially with regards to Kangaroo mother care and how we can expand on its use further. It has been very useful. And transitioning to the new speaker, next speaker, Dr. Suman Rao. She's a professor of neonatology and prior head of department of neonatology at St. John's Medical College. More importantly, she published the first paper on a large randomized controlled trial in 2008 in Indian pediatrics from a DM thesis from KEM Mumbai, which kind of tilted the systematic review of KMC and neonatal mortality towards saving neonatal lives, which ensured furthermore research towards Kangaroo mother care. She's also currently, if I'm not wrong, the secretary of the IAP neonatology chapter and working as a consultant to the WHO since around 2016. She recently she agreed for this lecture at a very short notice while returning in a cab from Ethiopia, where she had gone as a consultant for a randomized control trial. She was one of the authors of the IKMC trial, which Professor Vani mentioned, which was published in 2021. So she'll be basically speaking on IKMC and what happens henceforth and what has happened in the last 5 years since the IKMC study was published. I hope I have covered everything.
Yes, and a little more than needed.
Thank you.
Thank
Please
you.
go, please go ahead, Suman.
Thank you, Dr. Somshekhar, and it's a real privilege to be, and a little very difficult to be speaking after Professor Vani, our mentor, and as everybody has said, the mother of Kangaroo Mother Care. And I am now going to share screen with you all. Just tell me if you can see my.
Yeah, we can see all your slides together. Now,
Screenshot,
now
yes.
full screen. Yeah, please go ahead.
Thank you. And I have been strictly told to talk about the last 5 years and not before that. And I'm trying to restrict myself to immediate KMC and what has happened in the past 5 years in India on that. So it was on 27th May 2021, a little less than 5 years, that this randomized control trial was published in NEJM, Immediate Kangaroo Mother Care and Survival of Infants with Low Birth Weight. Now, this is the basis for the recommendation for starting immediate KMC. And we waited for this day very eagerly because we had the results more than a year ago, but it was embargoed that you can't talk about it till it was published in NEJM. So what was this landmark study? This was a WHO sponsored study, which is a multi-centric trial. And the rationale was that we knew since many years that Kangaroo Mother Care saves lives. It reduces about 40% of newborn mortality. But when we look at when it is started, in most of the studies, including the Cochrane meta-analysis, the mean age of starting KMC was around 3 days. And we also know that most of the deaths happen in the first 24 hours. And therefore, there was this big gap where babies potentially who would get benefit from KMC actually die before they get it. And that was the rationale for this IKMC trial, and the thought behind this, who conceived this, was Dr. Rajiv Bell, who's the current Director General of ICMR. And he always says this was the most difficult trial that I have done, because you are here now giving small vulnerable newborns, taking them away from medical personnel and putting them on the chest of the mother. And this was a study that we very closely monitored the main outcome, which was neonatal mortality. So this was a multi-country, multi-centric trial where we looked at babies between 1 to less than 1.8 kg, the really vulnerable ones, and they were randomized into 2 arms. In the intervention arm, it was continuous skin-to-skin contact starting immediately after birth, even before they became stable. So even if they had respiratory distress, they would be put on Kangaroo mother care and they would be provided the respiratory support like CPAP, as you see in this picture. All support was provided for breastfeeding, and even the babies on CPAP were put to breast. And we tried to do all procedures for the mother and the baby with both of them in skin to skin. Now on the control arm, we had to ensure that they got good quality KMC, because we didn't want a trial comparing high KMC versus poor KMC. And therefore a lot of effort was done to ensure that even in the control arm, when they started KMC after stabilization, we ensured that they provided KMC for prolonged periods of time. And I came into this study much later, after its protocol and all was well established. And I was brought into this as a consultant, as a monitor, and I already had some experience with early KMC. So I did not fear about putting babies who were unstable in KMC, because we had done a feasibility study in St. John's. We're putting babies not only on CPAP, but even ventilation on KMC, and we had published it. And I also believed in this already, because we had done another study where we looked at babies who got KMC early, and there in that we defined it as less than 3 days, not really immediate, and prolonged KMC, and looked at their outcome at 1 year. And we had found that starting early and ensuring prolonged KMC improved their BSID scores. So with this confidence, I had entered into supporting this trial across the 5 countries. And one of the big challenges was to get the mother and the surrogate for the baby immediately after birth. Most of the time it was a surrogate. Like you see here, there's a grandmother who is now slowly transitioning the care to the mother. And then there were space considerations. We wanted the mother to be there all the time to ensure immediate and continued KMC up to more than 20 hours. And that means if a mother comes in early, the obstetrician also has to come in. So we needed an obstetric and neonatal and nurse buy-in for this. So that was the beginning of IKMC in India, because Safdarjung was a very important site which contributed to the largest number of babies for this trial, led by Dr. Harish Chelani, and they established a beautiful mother newborn ICU. In fact, it was so good and the thought was so novel that I remember Professor Bhan, who had come once to St. John's, and wherever he went, he said, Delhi jayenge to Safdarjung jaake, KMC MN ICU mein you have to pay your respects. It was like a temple for newborn care, and this was the beginning of MN ICU or IKMC in India. And all support was provided to the baby, CPAP, monitoring, procedures done in Kangaroo mother care. And initially, the study planned to enroll around 6,000 participants. But midway in the trial, when we did an interim analysis with roughly around half the participants, it already showed that there was a definite benefit and it was unethical to continue the trial, and the trial was stopped in January 2020. And actually, it was very good, because we know what happened in February and March 2020. It was COVID times. And if the study had continued, I don't know how the study would have, how we would have been able to implement it. So luckily, the study stopped, and we took another year to publish this study. And what we saw was really gratifying. Even in the NICU, sick babies got on an average 17 hours per day of KMC, even when they were on respiratory support. And please also notice that in the control arm, The duration of KMC after stabilization was also very good, 19 hours per day. I mean, we hardly see these kind of numbers. So it for me was very important two messages. One is immediate KMC, and also the belief that you can do prolonged KMC up to almost 20 hours. And it showed that in addition to the 40% benefit that we see with KMC, it reduced mortality by additional 25%, and it reduced hypothermia as expected, and also sepsis, which was a little unexpected and novel for everyone involved, because there were a lot of people who started this study who were worried that infections would increase when the mothers came into this NICU. So there was a lot of dissemination of the results that we did, and some of these slides are also from that, and it was very nice to see Dr. Satyam make even a picture out of it and a cartoon he draw. And at that time of that year, IKMC was considered the top randomized control trial of that year by the EBNEO. And that was the basis for beginning of IKMC in India 5 years ago, because it reduces the neonatal death by 25% and has a huge impact globally. And the concept of MNICU is a total paradigm shift in the care of the low birth weight infant. Now, after we finished this, the next thing was to get a recommendation out. So 2020 trial is over. 2021, the trial is published. 2022, these recommendations came about, which talked about giving all babies globally kangaroo mother care for low birth weight and preterm before stabilization. And of course, it had another two important messages, that you do it for all low birth weight and not only less than 2 kg, and start at home or even the community. And very importantly, any cosmetic KMC of a few hours is not enough. You need to do at least 8 hours per day. So this was a very strong recommendation. And globally, a KMC working group was created to take this to scale and ensure it is implemented. And in the last 5 years, WHO has come out with many resources to support this KMC. In fact, when we talk about immediate KMC, it is actually only kangaroo mother care. If you look at the kangaroo mother care practice guide, we don't say immediate KMC and KMC. KMC is now to be started immediately after birth, and we have the practice guide which has just come out last year. We have the very good parent counseling guide, and a lot of these videos in this parent counseling guide have been shot in St. John's, and we were very glad to support it. And all these have now taken up KMC, including IKMC, on a global platform for all newborns. As soon as I finished my sabbatical with WHO and came back to St. John's, this was one of the first QI project I initiated again, because I believed in QI, I believed in IKMC. I did not yet have an MNICU in St. John's, but one of my DM residents, Deepthi, did this QI, and we actually said, okay, we'll start immediately for all babies, and for NICU babies, let's keep a goal of around 50%. And we did not exclude any baby at all, like even the ELBWs, 800, 700 grams were also part of this group. And with this, we did some PDSA cycles, as you see here, and we were gratified to see that we could start KMC for stable preterm babies, and we achieved our goal. But very importantly and surprisingly, we also managed to touch 80% for our NICU babies, including all the extremely preterm babies also being involved. So this was the first QI. And then in a year later, we established a mother newborn NICU, which you see here. I'll just play a short video. Ours is a small unit. It is a 7-bedded mother newborn NICU, but the mothers are all very, very happy. And for the first time in my life, I have now started seeing 22 hours of KMC. So if you want prolonged period, we have to get the mother and baby together. Anything you institute, you need to evaluate. Unfortunately, in the government sector, we do not have immediate KMC as of now. Even Dr. Srinivasan said that is such a loss. But there is, at least globally, a KMC indicator has come into play the nations have to report on it. Though it doesn't have separately IKMC, at least KMC is now a reportable indicator. So when we also looked at our data of after establishing an MNICU, obviously, I mean, this was nothing unexpected. We found that the duration of KMC hours was much more after establishing an MNICU. So I wasn't surprised with this. But what was very surprising was to see this, that the neonatal mortality, in my unit, the mortality was not very high. But still there was a significant difference between the two groups. Antibiotic days, probable sepsis, days of respiratory support were all much lower in the babies who were in the MNICU. Meanwhile, after this study was published, we know that KMC was, introduced in 1978. But even now, it's not to scale. So WHO had done a scale up of KMC1 implementation research in 2015. So it had learned that we need to do implementation research to find out the model which can scale up these new interventions quickly. So as soon as this IKMC trial was out, immediately Dr. Bell again wrote up the implementation research study, got it funded, and this was the WHO IKMC implementation research, which one of the countries was India. And this, again, like an implementation research, the idea was to get the model which could take IKMC in a district to more than 80%. We have completed phase 1 of this, and it's very gratifying to say that both the sites from India have achieved the target. And you see here that almost all the 6 sites have achieved more than 80% IKMC. So, and this is from the CEL site. This is from Ghaziabad in Uttar Pradesh, which was one of the sites for IKMC. And this was led by Vishwajit and Aarti from CEL. And they had some hiccups in the beginning, but at the end, they managed to get more than 80% IKMC within a short period of less than a year in a district hospital in Uttar Pradesh. And this has happened because of the close collaboration between the obstetrician and pediatric team. And now mothers are part of the care of the baby. So this is the IKMC model in Ghaziabad, where it is a continuum of care, where you have stabilization in the labor room OT, transport in IKMC, support for the mothers, and continued monitoring. And on the right side, you see how their model has established the high IKMC coverage. Thanks, Aarti, for these slides. The other site was Ambala, Haryana, and very glad to say that they managed more than 95% IKMC coverage in the district of Ambala in Haryana. This was the SAS site led by Dr. Sharmila. And meanwhile, I had also written up an ICMR small grant and got this grant to do this implementation research in a district in Karnataka, that's the Kolar district. And we are into the 3rd year of this study. We established an MNCU in the district hospital. The entire district team is extremely supportive, and we got funds for this from public-private partnership. And you all see here, one was the district hospital, and the other was also a very busy private medical college, Alapa Hospital. And in both these places, in a matter of just over a year, we have been able to achieve high IKMC coverage, more than our goal of 80%. And so what does it take to ensure that most babies get immediate KMC? And when we talk about IKMC, it's not only about starting. It's also about the average of more than 8 hours during the entire hospital stay, including the days you're on, say, phototherapy, sick, or whatever. So it's an average of more than 8 hours per day. And for this is the model we have from the Kolar district. I know you may not be able to read what is there, but what is very important are the champions. For example, in SNR hospital, in addition to the DHO and the RCHO, Dr. Sudhamani, whom you see here, she had an important thing. Every health personnel should experience IKMC, should experience KMC. And here you see the medical superintendent, postgraduates giving Kangaroo mother care. Even in Jalapa Hospital, it was due to champions like the HOD, Dr. Sudha, and doctors like Pravalika, who have really made this change in a very short duration of time. So one important, absolutely needed part of the model are champions who believe in it and who take it forward. What about IKMC elsewhere in India? As part of research, I'm sure many of you all will know about Sankalp, which is a national task force a study from ICMR, which is an implementation research across 10 different districts across the country in India. And here again, they are reporting immediate KMC and they are finding that in all these places, IKMC is increasing. In some of them, they've been able to establish an MNCU, but even without an MNCU, starting immediate KMC is a norm. There's another very important implementation research which is just started by ICMR. As you saw previously, this was all in the district level hospitals. But we all know that the teachers are the main trainers. So it's in the teaching hospitals that we need to establish all this. And that is what this precise implementation research does. Immediate KMC is an important component of this precise implementation research. The other three components are early CPAP, antenatal corticosteroids, and early enteral feeding practices. So as you see here, these are the big medical colleges catering to huge number of population with many medical students who are part of it, like Osmania in Telangana, Madras Medical College. They are huge places, again distributed across the country, and therefore IKMC is going to be a norm because these teaching hospitals are going to be doing very well and achieving more than 80% or 90% IKMC. One of the big fears has been that allowing mothers in, allowing surrogates into the NICU, which is supposed to be a very sacred and clean place, will it not increase infection? Even today, unfortunately, I face these questions when I go out and talk. I see SNCUs which are close to mothers. I see hospitals where mothers are still only a visitor who peeps into the, kanchka, glass house kind of. So what about KMC as an infection prevention and control tool? We know the science behind it. Definitely it decreases infection. But there is another study, a large cluster randomized control trial, a step wedge one, called the PRISM, Protective Role of Immediate Kangaroo Mother Care for Neonatal Sepsis and Mortality, which is led by Dr. Jeeva, which is happening across many centers in Chhattisgarh district. This is a 3.5-year study, and it's going to take some time to show us the results. So this was in the research setting, but what about program? The government of India has been extremely proactive. You saw that in 2022, the guidelines came out. In 2023, the FPNC guidelines is already advocating MNCUs and already advocating IKMC. And as you see here in the level of newborn care, MNCUs is part of the special newborn care unit, and the goal is to replace all SNCUs with MNCU. So establishing MNCU, we have the operational guidelines which was released by the Ministry of Health in 2025 last year, and this is the mainly going to promote the zero separation policy because keeping mother and baby together is needed for even the sick babies. The FPNC nurturing care module, of which Kangaroo Mother Care and Immediate KMC is part of, is ready, and the first TOT is going to be held early next month in KGMU Lucknow. So the government is doing a lot for promoting Kangaroo Mother Care, Immediate Kangaroo Mother Care. Already, as we know, these are details have got kindly from Dr. Sharmila. In Haryana, there are many MNCUs which are already working well. There are additional 4 MNCUs which are approved. And as part of phase 2 of the WHO IKMC IR, Kurukshetra District Hospital, the MNCU is now functional and the model is going to be implemented there. Similarly, in Tamil Nadu, thank you Dr. Srinivasan for this. We have 7 MNCU functioning and 8 more are sanctioned. But IKMC practice is quite the norm. With CEL as a technical partner, they are going top down. They're looking at medical colleges now having MNCUs. So we have an MNCU in KGMU, in RML Institute, in Lucknow, Varanasi BHU Institute, and also in Kanpur. In addition, some district hospitals, and they're also working in Jharkhand and Bihar. So KMC in program is quite well entrenched. The government has sanctioned a lot of money for this, and various states have written it in their PIP, and I'm sure that more and more MNCUs are going to be established. What about the private MNCU? Just last month, I had a visitor from this birth village, which is a very fancy birthing center, I'm told, in Cochin, who wanted to establish an MNCU and came to visit us. And they have recently established their own mother newborn care unit in this birthing village. So I'm sure this is going to be in demand both in public and in private. So what are the key learnings of the based on the progress here? You need champions. You need leaders who change policies. You need national and local champions, doctors and nurses. You definitely need an MNCU or an MNICU where mother and babies can be together if IKMC has to be practiced, if IKMC and prolonged KMC has to be done. But also please remember, these babies are sick, they need to be monitored. You need an adult bed where the mother can rest because she is postpartum, and sick babies very often come out from sick mothers. So she needs to be monitored. We need equipment. Obstetric neonatal nursing collaboration is a must. And therefore, we need more obstetricians in our group. We need implementation tools like binders, SOPs, counseling tubes, job aids, checklists, and we need training and mentorship. Data and feedback is extremely important. As NNF, as IAP, we need to ensure that the HMIS includes not just KMC, yes, no, but when KMC was started, how long did they give Kangaroo mother care? So this audit and feedback loops will definitely help, and we need digital dashboards and supportive supervision. So IKMC is definitely a roadmap to single digit NMR. These are photos from a small competition, or we had for KMC celebrations 2 days ago. And here you see the little one here. He was a preterm. He's now 4 years and he's giving KMC to his little sister. So as the mother, Princey, has said here, from receiving KMC to giving it, the sweetest full circle movement, and stillness is strength. Thank you very much for this for your hearing, and I stop at this. I had a small video of Princey, but I think for want of time, I will have to skip it.
Thank you, Professor Suman Rao, for sticking to time, and you finished exactly, I think maybe less than 25 minutes. So I don't see any questions in the chat, but so what do you think? I have a question for you, and it's like a general question. Over the 5 years, would you think you would be happy with what has happened to IKMC across India based on what information we have?
I definitely am very, very excited, and I'm happy to see the progress, because if you remember, Somshekhar, what took KMC from 1978 till now, it has been such a slow progress. Whereas IKMC is the hot topic, people want to do IKMC, mothers are happy, and the government has taken it in full force. And as you see, there is a demand from the public side. So whatever we see in happening as far as IKMC is concerned, I'm sure in the next 10 years, there is going to be a full change in the NICUs, and we will no longer have NICUs. We should have only MNICUs and MNCUs.
Thank you. So there is a question from Professor Samir, who is an assistant professor in neonatology. He wants to join the KMC MNIC TOT in Lucknow, I think. So can he join?
That will have to be, the request will have to go to the Ministry of Health and Family Welfare. Yeah, I just know that it is going to be held, but maybe we can communicate
it is specific for UP, or it is specific for India? What
I
is
think it is. I don't have more details, but I think it is a national level TOT which is going to be held.
Okay. Thank you. I think there are no more questions, and can go to the next lecture, which is actually mine. And I would request Dr. Srinivasan to keep time, and maybe at 4:20 tell me that there are 5 minutes left. So I will close at 4:25, whatever happens. Dr. Suman, you'll be there till that
Yeah,
time?
I can give you a reminder.
Yeah. So thank you very much, and I'll go ahead and share my slides, which are here. Okay. My full screen. Can you see my full screen, or what are you seeing?
Yeah, it's
We
visible.
can see your full screen.
Yes, sir.
Okay. Thank you. So, greetings from National Neurology Forum and AIMS Devgar. So this is one of the slides that is getting refreshed every few years because of new data that becomes available. So this is what we know when we mean kangaroo mother care, skin to skin care, uh, breastfeeding, early discharge, and structured follow up. And this is what leads to a lot of improvement that we have been taught in the last 1 hour, 1.5 hour or so. This is one of the slides, which is a generic slide, which I've been using for almost 15 years. And as you can see, better neurodevelopment is at the bottom of the slide. Because this was one of the few benefits which was when we started doing presentations on KMC, this was one of the things which was not very well known, and there were few studies, but that has undergone a sea change over the last, I think, about 10 years, when we have detailed reports of what is happening to the brain when the baby goes into kangaroo mother care. So this is another slide. This is, I think, slides from KEM Mumbai, which kind of tells you what are the various benefits of kangaroo mother care. I'll not go into detail, but KMC gives a lot of stimulation to the brain through the various 5 senses. So basically, we should think differently about kangaroo mother care as something that is building the brain, rather than what we generally think of it is improving temperature, improving breastfeeding, or decreasing neonatal mortality. So we should also be thinking that it is kind of improving the brain, and that, I think, will get more people to do kangaroo mother care, and will also improve the rates of quality of kangaroo mother care across. So this is, I think, what should be your advertisement for kangaroo mother care, rather than just saying that it is low cost, or it is improves breastfeeding and so on, and early discharge and so on and so forth. So this is the basis what we should be pushing for, and this is also what Natali Charpak, who is one of the founders of kangaroo mother care research, especially in Colombia, who believes in this. So when preterm birth happens, there are a lot of stresses. When a baby is in the NICU, baby can't sleep. There's a lot of painful procedures. There's noise, powerful light. Baby separated from the parents. Then the biological response, the HPA axis gets activated, and there's a lot of cortisol that gets secreted. So these are all proven by biological studies which are there. And Professor Vani mentioned about toxic stress a little bit in our presentation. So this is this toxic stress exposure, which is kind of a new definition, not only in neonates, but even in children, otherwise throughout infancy and childhood. It causes exposure on delicate developing neuronal circuits. So toxic stress has a very significant impact uh, on the brain. So this is the brain is formulating lakhs of connections, lakhs of neurons are being formed every second, and whenever this neuronal formation and the connection formation that is being there is being exposed to stress, that impacts how the brain kind of develops. Okay, so we have, as I mentioned, we need to change from the traditional view of survival to what is going to happen to structural neuroprotection. And instead of just focusing on KMC as something which is there in low resource environments where warmers are not there, or they're short supply, it should be the universal standard, as we have been pushing for in the last lecture we heard, where IKMC was given to almost In the trial, 17 hours, but you can even push up to 22 hours per day. Modulating stress and the various multiple sensations that the baby receives, all that can be modulated by ensuring that KMC is given right from the beginning. So the way we kind of move from just survival to kind of thriving and doing much better. So I'll show some of that in the next slides. So what happens is there is physiological stabilization when you start KMC. It improves thermal regulation, reduces apnea and desaturation, and limits intermittent hypoxia. It also reduces cortisol, improves autonomic regulation, and mitigates toxic stress. And there is improved breastfeeding, brain growth, and myelination, as well as continuous tactile, olfactory, and auditory stimulation, which happens. So all of these are interconnected mechanisms which improve and which bring about structural neuroprotection. So when you look at standard incubator warmer care, there is pain, stress, and there are just 2 slides on pain in this presentation, but pain also kind of disrupts the central nervous system, and Kangaroo mother care regulates pain and improves pain, and that is another way in which way it can improve the painful stress. Hypoxia also is reduced. There are a few slides on what do you say, blood flow in the brain, where it shows that also improves, and so cortisol spikes also reduce. So when you give KMC, it's skin to skin, there is improvement in autonomic regulation, stabilization of heart rate and respiratory rates, and improved pain responses. So there are various mechanisms which have been said, but one of the possible mechanisms is sleep does improve, and I'll talk a little bit about that. Breast milk production obviously improves, and we do know that giving improved breast milk or improved duration of breastfeeding, improved duration of exclusive breastfeeding, all of that has an impact on the brain. But it also not only impacts the baby, but KMC also impacts, because there are 2 skins that are there in skin to skin care. One is the baby skin, and the other thing is the parent skin. So the KMC also affects the parents, and there are studies which show that how it improves the parents' mood, activity, and depression. And when I mean parents, it's just not the mother; it's also the father and the siblings, or anyone who's giving KMC per se. So they all have an effect on neuronal connections, and disordered sensations can lead to poor neuronal connections, which I mentioned, and KMC modifies all this production. So I will skip the slides on KM breastfeeding. And there is a systematic review which is published in the WHO journal, bulletin of WHO, which shows that parental depression or maternal depression is reduced by giving Kangaroo mother care. So there are all these caregiving practices that improved, which we'll see in the 20-year follow-up study, and there is more stimulation to the newborn via talk, singing, movement, etc. So whenever KMC is being given, there are 2 people being affected. One is the person who is giving the KMC, which is usually the mother, and sometimes the father, and mother-in-law or mother, and the other is the baby. So not only do the benefits go to the baby, the benefits also go to the person giving the Kangaroo mother care. So in fact, there should be a competition as to who is going to be giving Kangaroo mother care, rather than saying that ki bahut ho gaya, 4 घंटे हो गए, 6 घंटे हो गए. So if you are giving anything less than 8 hours of KMC in it, you should consider that you are not up to the mark. So you're not having passing grades. So distinction is like more than 18 hours. And so if you want to look at it in that format as to how your unit is doing. Okay. So sleep organization is one of the most significant factors that improves the brain formation, and brain maturation and brain complexity also kind of change. There are various studies, EEG related studies which have been done, which have shown how KMC improves brain maturation and brain complexity. We all have sleep. We have various stages of sleep, and cycling of sleep. So our sleep cycles, we cycle over a few hours, but preterm baby's sleep cycle is roughly about 55 minutes. And if you look at how many seconds that the baby sleeps, it's barely less than a minute or 2 when the baby is on an incubator warmer, because the baby is constantly being disturbed. But when a baby goes on to Kangaroo mother care, baby completes its sleep cycle about 55 minutes. And that is the main reason why we say that minimum 1 hour of Kangaroo mother care. All right. So The sleep cycle is essential. We all know that if we don't sleep well, we are not able to answer well in exams. We are not able to remember things immediately. And not only our short term, but our long term memory and learning also is disrupted. So whatever you study during your exams, etc., and when you do pull out late nights, etc., you will not remember them in a few months. Same thing with the baby. So it's important that they have good sleep cycles and the brain plasticity is preserved. So sleep deprivation in the fetus, not only the neonate, also has profound effects on early sensory development and creation of permanent neuronal circuits for primary sensory neurons. So it's an active process. There are EEG waves that are related during REM sleep, which play a specific role in sensory system development. So the point what I'm trying to make is KMC improves sleeps of preterms, and that has direct bearing on neuronal development. Okay, and sleep deprivation between 30 weeks of gestational age and 4 to 5 months does result in delayed or disordered development of any of the various systems that we discussed. So motor, tactile, taste, sensory, and so on and so forth. Okay. This I mentioned earlier, there is hardly 10 to 20 seconds of quiet sleep, and mainly this is because of separation from mother and a poor caregiving environment. So there is so KMC increases the quantity of quiet sleep, has a non-chaotic sleep pattern. There's normal sleep cycling. There are less sleep arousals, and heart rate and respiratory rate variation is according to sleep cycles rather than based on what disturbance that is happening. And this I mentioned earlier. And baby goes to sleep usually within 5 minutes of starting KMC. So cycling is needed for normal neuronal growth, and KMC promotes sleep cycles. So these are pretty old studies, but these are this was there when we didn't have follow-up studies on KMC on the brain, which I'll show in a few slides further. So now the complexity also improves, the KMC complexity. So preterm babies who received KMC from 32 to 34 weeks had better brain maturation in whatever KMC measures that was done using EEG. So the EEG complexes show that the brain maturity is better in those babies who received KMC. And it was even better when compared to full-term infants. So this is the more interesting part. This is EEG analysis, and it shows that brain maturation was even better compared to full-term infants. There's another study which is published in 2012, which I'll show, where it shows that the rate of speed of movement of electrical impulses in the neurons is better in preterm babies who received KMC even as compared to term babies. So these are various EEG studies that we analyzed. There was better EEG complexity of the right hemisphere along with areas of left and right parasagittal regions when compared to preterm babies who did not receive kangaroo care. So infants who received kangaroo care had a significantly lower number of arousal rapid eye movements and indeterminate sleep, along with increased quiet sleep compared to infants who did not receive kangaroo care. This is from Ludington Ho et al. She is, I think, in the US, one of the states of the US, and she has come to India at least twice or once at least to present. And she has presented at many of her KMC conferences remotely too. And she's a nursing officer in the US, and she has done very good studies on EG and kangaroo mother care. So babies who received KMC had fewer REM sleeps and longer sleep cycles and higher percentage of quiet sleep. So very important for how sleep kind of improves. There's a higher baseline respiratory sinus arrhythmia with a more organized sleep wake cycle. And there are kangaroo has had lasting effects of at least 10 years. So this is when it was in 2014, and we have studies at 20 years also. Mental development also is improved. There is higher executive functioning at the 5-year and 10-year assessments when compared to the preterm non-kangaroo care group. I said I'll just show 2 slides. This is the slides from 2008. PIBB scores in those babies who received KMC were lower, which means that they had lower pain, and the time to recovery was significantly shorter. This is one of the earlier studies that we published in 2012, and there have been many more after that. Attachment improves. This is from, I think, Rohtak, where they showed that over a period of 16 months, those babies who received KMC, there was better maternal attachment. Okay, and mothers were significantly more involved in caretaking activities beyond the usual caretaking. Postpartum depression, I mentioned earlier, there's a systematic review in bulletin of WHO, which shows that KMC improves postpartum depression. Again, for IQ, there are studies which show that KMC infants had higher IQ than those given traditional care. So this is another study which is there. I'll skip the studies. These are more recent studies now. Kangaroo mother care and cerebral hemodynamics. This slide is from Dr. Ruchi Nanavati's presentation. But the paper that was being discussed is what we did in a preterm neonates in transcranial Doppler. So this was published in Indian Pediatrics, and we showed that KMC improves cerebral hemodynamics in clinically stable preterm infants. There is a subsequent paper published in Indian Pediatrics which shows that similar stabilizing effect of skin to skin care at birth, during delivery, or following delivery for 1 hour at least. So these are the various parameters that were checked, and how it showed how KMC improved cerebral hemodynamic circulation. The study published in Italian Journal of Pediatrics in 2014, which showed how it impacted cerebral blood flow for preterm infants. This one is published in 2023 May recently, and this is, I think, from RML Hospital, New Delhi, where they showed changes of cerebral blood flow parameters, where it showed there is improvement in cerebral blood flow after giving KMC. So how does it do? It stabilizes risk cardiovascular parameters, lesser fluctuations of BP, and improved perfusion index. They looked at, this particular study looked at NIRS, near infrared spectroscopy, which also showed there is a stable mean cerebral regional oxygen saturation throughout KMC duration. There is improved variability, and so basically it kind of ensures that there is physiologic stability. Okay, so this is the study that I wanted to discuss in detail a little bit. So this was published in 2016 Pediatrics. So this is a randomized controlled trial. This was initially published, the original publication is, I think, in 1998, and they had randomized babies to KMC and no KMC during that time. And study got completed in 95 or 96, and it got published in 98 in Pediatrics. And then they showed that there was improved mortality, improved weight gain, etc., in those babies who received KMC. So Natalie Jarpaketal, they went back and chased those babies who had now become adolescents, and recruited 178 of them into two groups: 97 who had received KMC and 81 who had received not received KMC. And then they studied what happened to their brains, and so various other things also. They showed that there was a direct dose response relationship with greater duration of KMC in infancy correlating with larger brain volumes in adulthood, adjusting for various co-founders. As you can see, they found there was a larger total gray matter volume in those babies who received KMC, larger basal nuclear volume, critical for cognition, motor control, and attention, larger cerebellar volume, and better organization of white matter. So this is what they showed. This was another study that was published 4 years before that, which showed how cerebral motor function in the same group, that is, how it changes, the speed of movement of a neuronal impulse. What they did is they applied transcranial magnetic stimulation over the primary motor cortex, and they looked at 39 in adolescents born prematurely, 21 who received KMC at birth, and 18 controls with no KMC, and also some 9 adolescents born at term. So they had both KMC, prematures with no KMC, prematures with KMC, and term babies who at that point of time were not receiving any KMC at all. Okay, and then looked at the functional integrity of motor circuits in each hemisphere and between hemispheres. So motor planning and callosal function. Okay, so it basically activates corticospinal cells in the brain, and it produces a response, motor evoked potential in the muscles of the contralateral side, and it is measured. And then they found out how these things kind of moved. Okay, all TMS outcomes are similar between KMC preterm babies and term adolescents. Okay, KMC adolescents presented faster conduction times, more frequent inhibitive processes with a better control between hemispheres. Okay, enhanced synchronization, conduction times, and connectivity of pathways in the KMC group shows that KMC positively influence the premature brain networks and synaptic efficacy up to adolescence. Okay, and as you can see here, controls had poor. This is what do you say, slightly poor. KMC had better ones over here, and you can see though there is hardly difference between KMC and term subjects. KMC preterms had slightly better outcomes than term subjects. So that difference was kind of startling. This study I mentioned earlier, where I showed those slides.
Dr. Somshekhar, 5 minutes.
5 minutes, okay. I think I should finish in 5 minutes. This is a study which I mentioned earlier. I mentioned they looked at something as a fragility index. So the more important point of the 20-year follow-up study is that KMC seems to motivate families to become more child-oriented. They tend to take their children to preschool earlier and provide support. It improves the father's involvement in neonatal care, which affects, it reduces divorces, reduces crime in the area. And so it changes the entire thing. And so it also found that the father's involvement changed the young adult's cognitive capacity. So this is a study that we did in Karamsad, where I used to work for around 26 years, where we followed up babies at 10 years for babies who are discharged from the NICU. We look, and so this was not a randomized controlled trial per se, but we looked at babies who received KMC for significant amount of time in the NICU versus babies who did not receive KMC for significant amount of time. And we followed about 708 neonates. They were recontacted by telephone between November 2021 to May 22. This is not published. This was presented in IP in 2023. And looked at anthropometric measures, arithmetic and reading skills, and looked at the various potential confinders. So this is a follow-up cohort chart. As you can see, 708 families, 233 families are lost to follow-up. 475 people were contacted. 270 did not receive kangaroo care in the NICU because they were discharged earlier. Okay, so people who go Dama, Lama, or who want discharge, they are discharged. 205 did receive kangaroo care in the NICU. Okay, and then 238 did not receive. So out of this, 32 died before discharge in the NICU. And look at this, 106 died because they must have got discharged early, and here there were 24 who died. And there were 179 completed home visits, and here, in those who did not receive KMC, there were 126 KMC visits. So these are the kind of the results. The 55% higher odds of the ability to add numbers in the KMC group, 56% higher odds of ability to read words, 30% lower odds of anthropometric failure, and no difference in having comorbidity. Then there is a 39% lower odds of cognitive delay. There is a 55% lower odds of composite adverse outcome among alive children. So this is a significant, findings which are there, and there is 83% lower odds of mortality, as shown in the flowchart of our study. So there was various statistical analysis which was done, but even after sensitivity analysis that was done, it did not show a change in the findings. So we use the fragility index of what was done in the Charpak study for analysis also. So KMC is in the NICU associated with improved cognitive ability, decreased anthropometric failure, and decreased mortality at 10 years of age. It's still strongest among those, even among those who are discharged against medical advice. So this is still not published, unfortunately. So what we have now, early functional outcomes demonstrate consistent developmental benefits, improved neurobehavioral organization and state regulation, enhanced socio-emotional regulation, higher cognitive motor skills as compared to conventional care. So basically, we need to move our way of looking at KMC and start KMC immediately and try and give KMC as much as possible. And so this is what we need to do. There's a Norwegian study, what is called as the IPIS-TOS trial, which found that there was no difference between those babies who received KMC and no KMC at 2 to 3 years. But the explanation given is there because both of the groups had excellent, good follow-up care. But even there, they found those babies who received KMC at higher language scores. So this is how we should kind of look at KMC, improvement in cognitive performance, improved in motor mastery, and better socioeconomic attainment, which is there. So on the top, we see what we do normally, and at the bottom, what is we see what we should be doing, improving gray matter function, etc. So pain minimization strategies, optimal nutrition protocols, and developmentally supportive environments are given to ensure that we do prolonged KMC for at least 8 to 24 hours. I think with that, I would end with this statement. In affluence, KMC is a valuable addition to infant care. In financial constraints, it's a precious gift. In poverty, it may be the only means of survival. Thank you very much, and I hope that I have finished in time. If there are any questions. Thank you. Since we are already delayed and we are at 4:30, I would thank Dr. Suman for reminding me, and I've finished in time. I hope I was able to convey the gist of what it means, why KMC is important for the brain. And I look forward next to Dr. Srinivasan to take over the
Yes, sir.
panel for KMC.
IKMC.
Yeah, IKMC.
Yeah, thank you. First of all, my thanks to Lalan, Amit, Upadhyaya, Somsekhar for arranging this panel discussion. And with due respect to Shashivani Madam, I will start the panel discussion now. See, first of all, I want to say that there are 4 people who are always willing to do something. What are the 4 people? The mother, who is carrying the fetus for 9 to 10 months, wants to carry the baby with her. That is her willingness. What is the willingness of the baby? The same in utero environment baby expects in ex utero also. The willingness of the pediatrician and obstetrician to have a nice baby. So the only answer for this is a zero separation of the baby from the mother. This is what IKMC. So I have 4 panelists here. I don't say panelists, they are the KMC champions. One, Professor Ramesh Chaudhary from Savai Mansingh, Jaipur. Then Professor Swetal from Baroda Medical College. Professor Anupama from Meerut Medical College. And Professor Sendil Kumar from Coimbatore Medical College. So the discussion today will be that. So Suman Rao, madam, was showing a lot of evidences, a lot of research articles, how this IKMC is doing wonderful things. But what we see in our country, when somebody is supervising, or when somebody is doing study, or somebody is giving a grant, that institute flourishes. What happened to other institutes? Why this IKMC is not a routine care of the neonatal care? So these are all the questions has to be answered. So long way to go, but still hopeful. So I'm going to discuss how we can make IKMC as a universal one in the country like India. What are the strategies and what are the strengthening? So my first question will be going to Ramesh Chaudhary. Professor Ramesh Chaudhary, you know, we have a lot of hospitals with per day delivery is around 10 to 15. Some hospitals will 60 also, especially in the state of Tamil Nadu. What I'm seeing in the hospitals where the deliveries are less, the IKMC is happening or trying to do. But where the deliveries are very high, especially in the medical colleges, even the DM institutes, this IKMC is very difficult to start. So even though there is a strong evidence supporting IKMC, many delivery room practice, still the skill-to-skin contact is not happening. Dr. Ramesh, what are the major clinical, logistic, and mindset-related barriers in implementing IKMC, especially in a high-volume centers like what you have in Savai Mansingh, where the delivery is more? What are the barriers? Can you enumerate? Over to Ramesh.
With my regards to KMC and NNF family, and regards to Sasivani ma'am, Dr. Srinivas, I just partly agree with your question. As we all know that it takes around 17 years to in evidence to be translated in clinical practice in full-fledged manner. And this evidence only just in 2021 being generated and published in 22. And within 4 to 5 years, the next year WHO changed this guideline. Lakshya program run by the government, they monitors skin-to-skin contact at birth across college to the every birthing center. And we see a lot many NICUs opening in and around us state. We have many NICUs in pipeline, maybe in the handover phase, or just we are just occupying the space. So I just say that I also agree with you that not all the babies are getting IKMC in delivery room as soon as they are being established. There are many reasons, clinical, logistics, and mindset. And it's big mindset. This is not just a merely protocol change. It's a change of philosophy of neonatal and maternal care. And that takes since years and years. And just like clinical and logistics, the mindset that I said at the outset, for the clinical, we may take, because the newborn and maternal care is being 4 parts. If it is normal, and 1 part extra by anesthetist, if that's a cesarean section. So pediatrician, anesthetist, nurse, and anesthetist, everyone is busy with their part. So we need someone who is just bonding them in. And that is one, like we have to train them, we have to show them examples, and I think we are doing it in a respectful manner. I just would like to highlight one thing. During last week, we conducted 3 NRP workshops with the postgraduates of the gynae of department and nurses of the labor room. And at the end, I asked them, what is your immediate to skin contact? And everyone, without any hesitation, said that it is being done in almost 100% of normal delivery, or I say vaginally delivery babies, not in the cesarean. They were very clear. Then I asked, what about the total 1 hour skin to skin contact with breastfeeding in labor room itself? They said that it is not practical in our circumstances because of that we are always overburdened with the work. Next mother is in queue for the delivery and we need a bed. So in short, it's manpower to load ratio, infrastructure of the labor room, and preparation of the mothers and families in antenatal period about that by involving family, because in the cesarean we may use family members and so many things. So it is not only the barrier of the knowledge or evidence. Evidence is there, knowledge is there with the pediatricians, obstetricians, residents, and nurses, but yet there are some lack, and I think we'll be covering it very soon. I think within very short of time.
Fantastic.
Thank
That was the conclusion is that the mindset of the 3 people, that is the obstetrician, the pediatrician, and the family, that should come together to implement IKMC in each and every center. And as Ramesh said, that till that time, I think the NICU should take the responsibility of having a dedicated staff nurse or a pediatrician to go and stand in the labor ward and start implementing the IKMC. Okay, I will go to the second question, Dr. Svetal. Svetal, when I was giving a lecture to the obstetricians about IKMC, many obstetricians, they showed a lot of reservations about it, because they found that it obstructs their work. The maternal workflow is obstructed. Maternal safety is also a problem. Newborn stabilization is a problem. These are all the problems they say. How, as a pediatrician, and as maybe the neonatologist also, along with your staff nurses, how you are going to convince these obstetricians and how you are going to build your confidence in IKMC with the obstetrician? Dr. Swetal, please.
Thank you so much, sir, for inviting me for the panel discussion in a short time. Yes, let us discuss how we will convince our team. Let us tell this, or let us consider obstetrician as our team rather than having a boundaries of obstetric department and pediatric department or an ICU. So if we are team and if you make a perinatal team, the labor room in a Dakshta program is a teamwork. If you see the national Dakshta program from Japaigo, it is a teamwork. So there has to be a joint SOPs has to be there, sir. We cannot just like give them our SOP that we want to do so being a cooperative. Because see, they are also concerned with the mother's safety along with the baby's safety, their protocols. There is also a medical legal aspect. So if we sit together and have a joint SOPs and build a team, have a multiple simulation drills, show them the anecdotes which created in the country across whenever the IKMC projects are funded by ICMR or WHO, discuss the research, start with small sample size. Like just now we are facing infrastructure issues, so we have started only with 2 beds. When we move to new building, we have a big MNCs. So government is ready for providing infrastructure, but here, as Ramesh sir says, as you said, we have to change the mindset, and without boundaries, we need to make a team with obstetricians, anesthetists, nurses, sit with them, discuss, have a QI project, have small, give them confidence. See, this baby was already on IKMC within 2 hours of delivery. Why can't we do it at birth? We are already doing skin to skin contact. We have to just extend the skin to skin contact and implement IKMC. So it is just a matter of building a team with obstetricians, with like-minded obstetrician. We can, we like Vani madam was invited to our city for a Foxy conference. She spoke. She tried to convince them. Similarly, we should have a lot of joint conferences rather than just having a boundary. We are invited for the conference or they are invited for the conference. Let us start with the perinatal team. Let us have, see, many obstetricians wants to do only gynec work, many obstetrician wants to do only obstetric work. So build a team of the persons who are passionate about obstetric work, and also take account of, like, take into team the nurses because they will be the backbone for this antenatal counseling. So even that first 1,000 days project or first 1,000 days the national program needs to talk about IKMC at the antenatal. We don't know who is going to deliver preterm delivery, who is going to have a low birth weight baby, right? So all mothers in the final trimester should have a counseling as we counsel for breastfeeding. Similarly, IKMC counseling has to be done. So that will help us in building across the country the IKMC implementation.
That's fantastic, Swetal. In fact, the government of India also has come out with a lot of proposals. I think
Yes.
previously the Lakshya program was different, Muskan program was different. Now the government of India has integrated both Lakshya and Muskan into NQuas.
Yes,
Hereafter,
yes.
you cannot get separate certificate for Lakshya. You cannot get separate certificate for Muskan. You will get both should be satisfied. Then get a certificate called NQuas. This is what the government of India a change in the policy. I think what Svetal said is correct. I think Lalati and Amit should note that first time the government of India has done a CME or workshop or a work training along with obstetrician and pediatrician for stillbirth. They have done
Yes.
for stillbirth
Yes.
first time. The
Yes,
government
yes.
of
At
India, they have
Bhopal.
done for stillbirth. Now,
Mhm.
yeah, now I am able to see that this stillbirth is coming out nicely with all the things, what are the stillbirth, what is intrapartum causes, antepartum causes, everything is coming out in consultation with pediatrician and obstetrician. I think those kind of things should happen to have a see so that we can take the obstetricians also in our board so we can be successful program. Thank you, Svetal. The next question goes to Dr. Anupama. Anupama, see, there are people who have a lot of beliefs, cultural beliefs, sometimes fear of holding the baby, some misinformation. Some family will resist. So many things are there. And more importantly, you cannot go and say, put IKMC to the mother or to the relative without any previous antenatal counseling. So what is your strategy? How you are planning? What sort of antepartum counseling you are going to do? How you will drive out this cultural belief, misinformations and fear and other things? Over to Anupama.
Good afternoon to all. Thank you,
Yeah.
sir, for this literally a very important question. So the first thing which came into my mind after reading this question, we don't get referral in antepartum period of the from the obstetrician friends. So it is very important. We get referrals only if there is some congenital anomaly detected in the antenatal scans. Otherwise, normal deliveries, normal antenatal scans, normal antenatal, there is no fixed policy that pediatrician should be consulted before the delivery of the child. I think one important point is our gynec ops friend should make it to the point that every antenatal patient should have at least one visit to the pediatrician before the delivery, so that we are
Yeah,
able to
exactly.
counsel the mother regarding the breastfeeding, regarding the IKMC, because to implement IKMC, we all should be on one page: ops, pediatrician, our labor room team, and the parents. And during that visit, we can talk to the family, we can address all their fears, we can address all their custom beliefs. Secondly, as a pediatrician, I want to have the antenatal separate OPDs, because if we are having a large number of people attending OPDs and this patient came and want to talk to me, I should give some time, because to making them believe a new thing. For them, it is a new thing, a new change in the delivery system. It is very important to give time to address all their problems. So, one more important thing I think we can do is separate OPDs for this patient for antenatal counseling, where we can counseling about their breastfeeding, about the IKMC, because it is coming up one of the most important component after the neonatal in the neonatal period. So more emphasis, more time, separate OPDs, and taking more in confidence the our ops friends is also because only implementation of IKMC is not for the pediatrician. It should be all over the medical system.
I think you are giving a beautiful points, Anupama. Generally, these obstetricians refer to the pediatricians for fetal anomalies. The
Yes,
baby's
sir.
got hydronephrosis. The baby has got congenital heart disease, whether I can terminate the pregnancy
Uh,
or not. But
yes.
now you have brought a point that even for the normal babies during the antepartum care, maybe some opinion to the pediatrician regarding what is the breastfeeding, what is KMC, what IKMC, that should be practiced. But is it possible, like country like India, where we have lakhs and lakhs of deliveries happening in the government system, is it possible to do? And more importantly, your suggestion of antepartum counseling, at least one counseling with the pediatrician, I don't think it is not happening even in the corporates and private hospitals. No, is it happening in the private and corporate hospitals at least, Anupama?
No, sir, it's not happening.
This anti,
But sir,
yes.
it's sir, for
Okay, that's
implementation, it is very important to make a change in the
Yes.
mindset of the people. We have to do is make
We
it a
should
very
bring a
important
change in
component.
change our system.
Yes, sir.
Not
Yes,
only
sir.
anomaly babies, normal babies also should be sent to the pediatrician for one opinion, right? That is the
Yes, sir.
right point you have brought. Fantastic. I think our NNF, Lallan and Amit should note this point. This is a very important change, game changer. Even
yes,
normal
sir.
babies
And
during the antepartum period can have a visit to the pediatrician and just talk about how the baby is there, how the baby is rotating, how is the amniotic fluid, how the nutrition for the baby, whether breastfeeding is adequate. All these things should be discussed in the AIM period. Amit Anupama madam has told. Important, very important country. I'll go to the next question. Dr. Sendil Kumar. Sendil, you are a neonatologist. You are doing aggressively IKMC because you are the person in Tamil Nadu state bringing out most of the babies, including 800, 700 grams, doing really well. And your salvageability of this extreme preterm babies is almost 80 to 90%. Sendil. But I will ask you one question. when you do IKMC, especially like medical college like Coimbatore, suppose something happens during the transit period to the baby in the form of some complications. Suppose that may boomerang the system, and the people may say, is it right to do in IKMC? Baby has got complication. Now, as a neonatologist team, how you are going to anticipate this complication? How you are going to answer this question? Dr. Sendil Kumar.
Sir. Good evening, sir. Good evening, dear
Yes,
forum.
yes.
Sir,
Yeah.
Thank you very much for this active discussion, sir. Sir, thank you for your kind introduction, sir. Sir, first of all, sir, the question itself you have asked, sir, complications developed during IKMC. I want to take that. I want to divide it, sir. Sir, this is like you give surfactant to preterms, more the babies who have received surfactant died like that. But the real meaning, severe extreme preterms with multiple functional organ disease or very extreme preterms, they will die, sir. That is not surfactant is not the cause. Like people used to say, more the surfactant receive, more the babies die. It's not like that, no, sir. So it's not complication which arise due to IKMC. It is baby's vulnerability. First, that thing we should understand, sir. With the vulnerable babies, that we should be vigilant enough so that we should have a clear clinical protocols and eligibility criteria, sir. We should be somewhat flexible. So the baby is going down, it's in shock. At the time, we should have a clear protocol. These are eligibility criteria for beginning immediate KMC, and these are the eligibility criteria where we should take and we should do something else, and then putting back to KMC. These protocols should be there, sir. For this, the person should be trained, sir. Each and every person.
Exactly. The person handling should know everything now. Go on.
Sir. Then we need to integrate monitoring, sir. It should not be like IKMC or no IKMC. It's not like that, sir. We should integrate both technology and no technology. This is simply, if we talk about IKMC, people used to say it would be followed in low income countries. So it's not like that, sir. Even in Sikh extreme preterms, if you integrate monitoring with this IKMC, definitely, and we should train the persons, nurses, and parents has to be trained. Parents too has to be involved, because if some complications has arisen when they kept in KMC, next time if you ask them to do, they will hesitate. So we should make them understand it is the baby's problem. Even if the baby would have been in warmer or in incubator, this problem would have occurred. So don't worry. These are the things, early things you should find out. If you find these changes, we need to give them due respect, even for the minor changes. If they inform us, our nurses team, our team, neonatal team will give, which should give due respect, and we should look at the things, and we should develop a scoring system like we use for neonatal transports and all, scoring systems where we can have a flexibility at those times.
Before IKMC, after IKMC, during IKMC, something like that.
Yes, sir. That's what, if you then counseling and using that, and we should keep on using data, sir, to convince the neonatal team. We should have a review meeting and we should say, see, evidence is going on changing. Now we can use as sir, we have started MNICU, and we can use our evidence to SOCAS in district referral centers. See, after beginning this MNICU, almost the hospital stay has reduced, the usage of antibiotics has reduced. We have discharging it earlier, like that. We should keep on use our data to create awareness among this, sir. This should be individualized, sir. If we use the individualized and monitoring, vigilant monitoring, and all the trained peoples, definitely we can succeed in managing these complications, sir.
Sendil, regarding this reservation, that is the complication during IKMC, that is from the labor ward to the SNCU, mostly you expect the reservations comes from the parental side or from our own nursing side. I feel our nursing side will be more worried rather than the parental side. So how you are going to overcome this?
That's what we need to. First of all, we need to train them, sir. Lack of training and lack of awareness is the issue, sir. We should keep on saying this is the evidence. This is what previously they didn't follow delayed card clamping, sir. Now we have made out to national policy and we are doing it. And we are saying that national delayed card clamping or card milking is not a danger in term babies. You can do it. It is very useful, very useful. We should keep on telling them, and the resistance can be broken only if if we make some trained team work for it, so that the rest of the sisters and team will understand and they will keep on following.
Okay, beautiful, beautiful. The next question goes to both Ramesh Chaudhary and Sendil. Both can answer the fifth question. First, Ramesh Chaudhary will be answering, then Sendil can answer. I think Ramesh Chaudhary is not saying. See, for example, now our NICU is completely technology dependent. In fact, as an health advisor in Tamil Nadu, I am putting equipment for 22 crores for this PIP program. 22 crores, mostly our equipments also. In fact, I am at one point I am going and procuring giraffe INCU armor also for some of the centers. So it is mostly technology driven. What I'm trying to ask you, from a emotionless equipment to the emotionful mother. That's what I always feel. I say emotionless equipment and emotionful mother, which I feel emotionful mother is great. Dr. What the government or the National Health Mission or policy makers can plan in integrating IKMC into the neonatal practice, for example, training, infrastructure, making us a part of the system. So, Ramesh, can you say what the government is doing something? What extra thing can be done by the government? Ramesh can say some words. Ramesh Chaudhary. Hello? Ramesh is not there? Ramesh Chaudhary? Sendil, am I audible?
Yes, sir. Clearly audible, sir.
You can start, then Ramesh can join also.
Yes, sir. Sir, first of all, we should consider this IKMC should not be an optional practice. It should be like standard of care. Now, see, whatever, when you preterm with respiratory distress, this is what we teach our postgraduates. Any preterm with respiratory distress, CPAP is a choice. Like that, it will become a standard of care. Like that, in our NICU, we should make this as a standard of care. So, this standard of care should be coming from
one point.
Yes, sir.
Okay. Only one point. Even in our FBNC portal by the Government of India, there is only one word called KMC duration. There's nothing called IKMC in the FBNC portal also. Okay. Unless and otherwise it is in the portal, people may not be doing and we cannot get the report also, right? So you want to be in the system. Yes.
Yes, sir. We need to embed this IKMC into national care policies and standards, sir. Then only we should endorse. This policy endorsement only makes it from optional practice to standard of care, sir. That we are supposed to do. And the thing, even in our, sir, I used to go for this NICU accreditation, sir. In our NNF NICU accreditation for this PG trainings, we used to go, sir. Even there, separately, we should make it mandatory for this KMC and KMC. See, in our state, with your help, now we started entering how much hours we are giving KMC, whom, and from day one itself, we started entering. We are collecting the data and we are reviewing it. Like that, this has to be, even when they ask for the birth rate, death rate, like that, they should ask for KMC hours, overall KMC hours practice in preterms. In all those things, it has to be integrated in accreditation. All those, which need to reorient the health systems from infrastructure centered to family centered, sir. This has to be done. Finally, this workforce training, all those, sir, if our each and every hospital worker, including a sweeper, our basic health worker, nurse, and every person has to know about this. If they has to know about this, government has to publicize, sir. They should make aware. This is a very use. Almost this has to be practiced everywhere. This should be the standard. Like that, we need to make people aware about this, and always we should ensure appropriate monitoring and supporting services. Just like that, in for example, in a remote area, practicing this IKMC is the relevant. Like that, we cannot tell them, sir, because if the baby develops we know vulnerable babies develop complication. If we put them in IKMC, develop complication, it will become an issue, and later on those village sector and those places, they won't practice KMC. Rather, doing just in low income, rural areas alone, we need to do it everywhere, integrating the monitoring system and strengthening it. This has to be done, sir. And this
Thank you,
has to be
Ramesh.
done.
Ramesh. Yeah, Ramesh Chaudhary.
And
I
this
think
has to
Ramesh
be
is
done.
not there.
Yes, I'm audible.
Yes, sir.
Yes.
Yeah, Ramesh, I hope you heard what Senthil was saying. Ramesh, you want to add on to that? What NHM government should do and implement and integrate this IKMC into the system? Your words, please.
I was disconnected a bit. I heard
And
Senthil for
no
half
issue,
the
no
time.
issue, no issue.
I just
You can come.
would like to suggest that government is supporting, but I just want
Yeah.
to add upon that it should be a gradual transition, not to abruptly remove everything, because nowadays we are in machine first mode, and we have to transit to the mother
Yes.
first mode, and we
Yes.
have to change our mindset that mother is not a visitor. Mother is a
Yes.
neonatal
Part
infrastructure,
of
and that thing
Yes.
will going to help us. And second thing, this is a continuum of process. It should start from the ANC and should be ending at postnatal ward, and in between labor room, NICUs, and every facility should be supporting. And this all can happen by the government's funding, support, monitoring, and continuous training. That's all. Thank you.
You are right, Ramesh. In fact, I am planning to discuss, being I am in the Tamil Nadu health system now, maybe planning to discuss with the Government of India, IEC, Information, Education, Communication, for this IKMC should start from the labor ward and AN ward. That's what I feel. So far,
Yes.
not much IEC materials were available, except Shashivani madam doing lot of things. I don't see anything from the government system doing an IEC for IKMC. I'm not talking about KMC, about IKMC. Maybe this is the time we should impress upon IKMC, IEC materials from the Government of India, show to the public, put it in the TV, let the people watch in the antenatal ward,
Yeah.
so that it will become a real boon, actually.
Yes.
And next question, I will go to the last one, to Sweta and Anupama. See, madam, this is the most important question. So far, we are talking about nurses, obstetrician. We put the blame on the obstetrician. But what I see is the blame should be on the neonatologist also. Because I have seen in Tamil Nadu, any of the corporate hospitals, I think nobody is doing IKMC, even though a lot of neonatologists are available and other people are there. So, in fact, I heard one word, one of the topmost neonatologists told me it is a double-edged sword. I could not understand the meaning of double-edged sword there also. So, I think Swetal and Anupama, you tell us, leave alone the staff nurses, leave alone the obstetricians. How are you going to convince many top neonatologists in the government system and also in the corporate hospitals to accept that IKMC is the game changer? What is your opinion, please?
Shall I start, Anubhava ma'am?
Yes, ma'am. Yes, ma'am. Please.
Sweta,
Okay.
you can tell,
So
then
I will-
Anupama can join later. Yeah.
Yes. Thank you. Convincing our highly neonatologists who are highly involved with caring the critical preterm and ELBWs. Definitely, they will be skeptical because they are worried about the patient. See, all of us are. Our goal is one: the safety of the newborn and survival of the newborn. So they have a safety concerns. There are lines going on, the treatment, the dislodgement of the ET tube. So there are safety concerns. They are skeptical about it. So the centers like Dr. Senthil Kumar, who is already practicing, Dr. Suman Rao ma'am, there are many centers who have already started practicing. If they come out with the success stories, if there is a hand holding, if there is a pre-training of these nurses who are handling this along with the neonatologist, I think we can overcome all this skeptical, all this ifs and buts. There has to be a protocol. Senthil Kumar sir said that there has to be a clear protocol that if the a baby is on inotropes, invasive ventilation, wait for this, wait. But if the baby is on CPAP, if the baby is on NIMV, we can definitely go ahead with the IKMC. So if the units sit together and write their protocol and go ahead, I think this all ifs and buts will be solved. And especially
Anupama?
the training.
Yes. And
Yes,
maybe
ma'am.
Sir,
Shwetal, maybe Shwetal, what the government system has got so much of exposure and training should be given to the private corporate neonatologists also. Am I right? Exposure and training. Anupama, you can go on.
sir, Sashi ma'am want to add something.
Yeah,
Sashi ma'am.
final
Sashi ma'am.
comment, Sachivani, final comment will be Sachivani madam, because Sachivani
Okay.
madam will not
Sir,
accept all these things.
just I want to
She
make
will say
one.
every baby has to, yeah.
So
Sachivani
one
madam will
point,
be the
yes, sir.
final scorer,
Okay,
yeah.
okay. Okay, sir.
Yeah.
So just I want to add something to the Shwetal ma'am. Shwetal ma'am has answered very beautifully to your questions. Sometimes the mother is the best who is monitoring the baby. On ground, sometimes the mother is the only person who talks to us कि मैडम आज थोड़ा ना वो एक्टिव नहीं लग रहा है, आज इसका पेट थोड़ा फूला हुआ लग रहा है. तो mother is also monitoring the baby. We should include her in the monitoring part. मतलब उसे अलग करके हम अपनी इंटेंसिव मॉनिटरिंग को अच्छा माने, दैट इज नॉट जस्टिफाइड. तो मदर शुड बी अ पार्ट ऑफ आवर. यस सर.
Yeah, that is the concept of MNCU also. That is the concept
Yes,
of
sir.
MNCU also. That's why the government of India has brought MNCU, because when my own nurses were resisted MNCU because of lack of HR, I told them, mother is the best nurse. You are the second
Yes, sir.
nurse. Don't worry about the
Yes, sir.
workload. I told her also. So MNCU definitely will solve this problem. I request Sachivani madam. I think Madam Svetal was saying that endotracheal tubes, NG tubes, other sickness, is it not feasible for the baby to transport in IKMC? Madam, Sashivani madam.
No, sir, I am not saying that. I am saying that we need to show them the results.
Yeah,
The
yeah, okay,
neonatologists who
okay.
are skeptical, we should know, the champions should show them the results that it is not
But
a barrier.
some reservation, yeah, some reservations are there in some centers which I can see in Tamil Nadu also.
Yes.
In fact, I have visited many. I called them, "Are you doing IKMC?" What?
So
What? This is the
champions should be the
answer.
leaders to convince the
Yes.
neonatologists.
Correct. Sashivani madam, you want to have any point, madam?
Now,
I think
only
madam is
thing
not.
is, can you hear me now?
Yes,
madam.
go on, madam. Go on, madam.
So my point is we should sit together and work out these protocols. In my presentation, I have briefly
Yes,
covered all these points. Because of the time
yes.
limit, naturally, I could not discuss each one in detail. But I said, for
Okay.
example, for immediate KMC in the for the cesarean delivered babies, you discuss
Yes,
with the obstetrician, anesthetist, operating room nurse, and together you bring out the protocol, and accordingly, if you work, it is successful. I have visited several hospitals abroad. Particularly, I must mention one hospital in Scotland where they have a very systematic, means they have one OT only for cesarean. One after another cesarean goes on. But automatically the neonatal nurse is there, and an additional KMC provider like a father or somebody is already there. And with the anesthetist, they have an understanding. On the right side, they will have the drape. On the left side, the attendant will be staying. And that additional care provider will enter the OT only at particular time. And like that, systematically, every small details have been worked out, and it works very smoothly. So then only we feel if they can do it, why we cannot do it. So like that, there are so many examples. We can sit together and work out. And for these only, I request now bodies like NNF should take a lead. Because as an individual group, if we speak, people may not listen. But as a part of National Neonatology Forum, along with the other colleagues, we sit together and work out each topic we take up, work out the protocol. It should be workable. There should not be any problem. And
thank
so,
you, madam. Thank you for.
yeah.
Madam. Yeah, madam.
No,
Go on, madam.
take one part, say for example, immediate skin to skin contact in the delivery room. What are the exceptions we know?
Yes.
So accordingly, we should do the audit.
Yes.
Then accordingly find out why it was not done in a particular baby where we thought it can be done. So lot of efforts are required. audit and analysis and feedback, at least to begin with in a few centers it will be required. Then it will be acceptable and taken up by everybody. That is how we
Thank
went.
you, madam.
Even in newborn care or breastfeeding promotion or introducing surfactant, every level, stage-wise, we have gone through this.
Thank you, madam. I think I thank all the panelists who have given you beautiful answers for each and every questions. And I want to finish off saying 5 points here. Number one is many of the pediatricians feel when there is a delivery load is less, I am able to do IKMC. When the delivery load is more, I am not able to do IKMC. I think that should be clearly written off, and we should impress upon them that whatever be the delivery load, it can be done. Point number one. Point number two, in the FBNC portal in Government of India, only they say KMC. How many hours? Nothing is there. Now the government of we should insist upon FBNC portal about IKMC also. Whether that baby was given IKMC or not, that should be included in FBNC portal. Point number three, madam, most of the work is being done when there is a government order, when there is a government GO. The government GO says that those eligible babies, especially low birth weight babies, should be taken in IKMC position to the nursery, then it will work. In fact, I am having a new government which has connected very emotionally with the people, and this new government is very responsive government. Let me see whether I can impress upon the new government to issue a government order for IKMC. Let it be an example from the country that Tamil Nadu is issuing an order for IKMC for all the people to practice. Then it will happen even in the private people, because we have got a beautiful system called pick me entry. Pick me entry means where even the corporate hospital has to put the pick me entry. All the AN registration Tamil Nadu has got now in hand, because private hospitals also putting in the pick me entry. Similarly, in the pick me entry, I will bring IKMC also, so that the private hospitals, corporate hospital, government hospital has to enter whether they have done IKMC or not, for especially for the low birth weight babies. But anyway, this is really shining that IKMC is becoming a big game changer now in the the protection of newborn babies. Very soon, I think the country can see a revolution in IKMC. Thank you, Amit. I just end my panel discussion, thanking all the four panelists, Dr. Ramesh Chaudhary, Dr. Svetal, even though it is done in short notice. Today, early hours only, I sent the questions to them and they responded immediately well also. Even though it did in short notice, I think they have come up really well. I thank the panelists and the NNF team, Lalan Bharti, Amit, and Ravi Chachan for giving this opportunity. Thank you.
Thank you, sir.
Thank you.
Thank you, Dr. Srinivasan and the team
Thank you.
for doing a wonderful panel. Dr. Lara, you want to make some comments before we close? You are muted, Dr. Lara.
It was really excellent discussion, excellent input, and together we can take it forward. And for that, we need to bring all the stakeholder together. Very good input that not only NNF, but the Foxy and other people has to come, and they should speak the same language, then the impact will be more. And in this direction, NNF has already started, and we have already been doing this perinatal synergy, and we have kept this one of this topic there in the discussion too.
And I just want to make a point. Dr. Rita Raseli has put up a comment. Family members and grassroots level workers should also be provided orientation and training for continuation of KMC at home following discharge, which is a correct comment. In the chat, Dr. Suman has posted a link for IEC material from the WHO. Those who are here can pick up that link and use it. I think
Somsegar, in fact, in Government of India, it's called Home-Based Newborn Care Program, HBNC, where the ASHAs or the field staffs has to visit on 3, 7, 14, 28, and 42 days, 5 visits to the newborns. This home-based Kangaroo mother care is being implemented and watched also. The training also, the Government of India and Tamil Nadu is giving training for all the field staffs regarding KMC also. Yeah.
Professor Vani wants to say a few words.
See, we have already requested government to include home-based KMC as a part of home-based newborn care protocol, which has been accepted, and since 1 year we are working on it. And we have produced modules for different states also for home-based newborn care, and even for those working in the remote areas. And even for the tribal areas, now we are coming up with certain different recommendations. They are all different in different places, but we are working hard on that. And there are quite a few publications from KMC Foundation also, means recommendation charts and all those things. People can refer our website and get those things. Thank you.
Thank you. With that, I
Thank
think I would like to thank all the speakers, starting with Vani Madam, Suman Madam, Srinivasan Sir, and panelists, Dr. Verma, Dr. Bhatt, and Dr. Senthil, and Dr. Chaudhary for joining and sharing the knowledge. It has been actually a very interesting panel discussion. We actually have finished on time because it started at 2:30. We're supposed to finish by 5 o'clock. So thank you to everyone. I thought that I think we had a very short opening session. Thank you, Dr. Laran Bhatti, for not stretching it too much. So it was good. And we hope that we'll be able to do this again year after year and continue to work together to ensure KMC reaches every home. Thank you all.
We
And I
should
think
continue, not we should wait for 1 year. We should continue.
Yes.
Yeah. Similarly, Lallan, one more point.
Yeah.
I want to highlight. See, our NNF is doing a lot of workshops. I can see a focus workshop, ventilatory workshop, this workshop, that workshop. Only Sachivani Madam is conducting KMC workshop and KMC conference. Why can't the NNF do all these workshops? KMC. This is the point I want to highlight also.
Sure, we will see, sir. We will do that also. In fact, we had trained around 200 KMC champion. Ma'am might be knowing at that time when I was secretary and UNICEF supported, and we had trained around 200 neonatologists to take this mission forward. So we can again see now government is taking it forward. So NNF will definitely support this program.
See, only
Dr.
government.
Ravi
Suman,
Chang is Ravi. Yeah, Dr. Suman, you want to say?
Dr. Suman
Yeah.
wants to say something.
Thank you for this wonderful opportunity. My only plea with the NNF office bearers is to involve obstetricians in this. Without obstetricians, Kangaroo Mother Care and particularly IKMC will not take off. And it needs to be a guideline by them, a very strong guideline in which there is part of the training also. That is something if we can do with Foxy, it would be great. Thank you.
And similarly, even the nurses also, they also play a very important role. So we have to involve them also.
Thank you, ma'am.
Thank
I
you.
think
Thank you.
Dr. Laran, Dr. Ravi is not there. I already gave the vote of thanks, so I think we should.
Okay, thank you.
Okay.
Thank you so much.
Thank you very much.
Thank you. Thank you so much.
Thank you.
Bye, everyone. Yeah, bye.
Thank you,
The
NNF,
screenshot
for
later.
accepting
Can
our
you take
request.
the screenshot?
Thank you, sir.
Thank you, ma'am.
Yes, sir.
एक आप वो ले लो देवरुण और स्क्रीनशॉट ले लो.
Now, all of you, please
Stop the
put
video,
your
yeah.
video on. Put your video on.
Thank you.
Taken, sir.
Okay, thank you very much.